Welcome to the Beverly Hills Plastic Surgery Podcast. This is an exciting podcast. Dr. Ravello, are you excited?
I am super excited.
Here with me, as always, Dr. Millicent Ravello, to talk today about our new series, the Plastic Surgery 101 series of podcasts.
Bringing it back to the basics, everything you need to know about what we do in plastic surgery. So we've been doing this podcast for 3 years now.
Yes.
And we have covered an entire breadth of plastic surgery. There are still topics out there that we haven't touched on, but we've covered just about everything. And a lot of what we've covered, we've gone into very specific depths and specifics on specific separate podcasts. And what we want to do is sort of just bring it back to some of the original basic plastic surgery procedures that we do, because we did most of those in the very beginning of this podcast, and so people would have to scroll through 3 years of podcasts to find those.
That's true.
And so we're kind of going to start over a little bit, but not really. I think, as we touched on with the recent podcast, things change so quickly in plastic surgery. So there is a solid chance that the things that we say today about breast augmentation might be a little bit different than the things we said 3 years ago about breast augmentation.
Yeah, I mean, it changes rapidly. That's why we go to all these courses and stay updated. And, we were just in Las Vegas at a course, and there were things that are new, and there are new consents we have to use. And there's a patient checklist and a black box warning. And there's all this stuff that keeps coming around, and then some of it goes away. Oh, you don't have to do that anymore. Now you have to do this.
Right.
So yeah, it changes. You cannot sit there and just say to yourself, we are going to, live and die by what we learned as residents. It is so what I learned as a resident in the Stone Age is dramatically different.
Obsolete at this point.
It is. It's obsolete. Yeah. And so now, doing this Plastic Surgery 101 series, we're going to start with breast augmentation today, but we're going to go through everything. We're going to go through facelifts, lipo, you name it. Right. And we're going to bring home the basics for people. And as always, we always dive deep somewhere along the way.
I know. We get a little off track, and then we have to bring it back in. But we're really going to try to just stick to the basics here with breast augmentation, what you need to know, a primer.
So let's do it.
Yeah. So, first things first, the patient that comes in for a breast augmentation. These are the things that your surgeon is going to ask you because they are pertinent to what you want to achieve. Number one, what size breast do you currently have? Number two, do you have a history of childbirth, pregnancy, breastfeeding? Number three, do you have a history of weight loss? Number four, do you have any other medical problems? Number five, what is your desired goal? What are you looking to achieve?
Yeah, and I think one of the things, too, for our listeners to kind of understand in that medical history is there a family history of breast cancer?
That's huge. Family history of breast cancer. When was your most recent mammogram? If you were of mammogram age, have you ever had an abnormal mammogram? Everyone has a little bit of a different recommendation. I think there's different societies that recommend mammograms at different ages, but I think in general 40-ish is when most women with average risk factors will start getting mammograms. I start having any of my patients over age 35 who are going to have breast surgery get a mammogram. And that's only because I'm so much in the breast reconstruction space, and I'm seeing breast cancers being diagnosed earlier and earlier in patients. And what I don't want is to go in and do a breast surgery, rearrange the breast, cut through breast tissue, only to find out that patient had an active cancer, and now I've potentially dispersed the cancer, throughout the breast. So these are the things that we need to make sure we clear before we do any breast surgery. So yes, that is why personal and family history is very important for breast surgery.
So once you have that information kind of pulled together, how big do you want to be? I always say, and by the way, grab some photos of breasts that you like.
Super, super helpful, because if you come in and tell me you want to be a 32D, and then you show me a picture of someone who is like a 32H, I'm like, okay, well, that's helpful to know, because those are two very different things in my mind. So photos just sort of make everything an even playing field. I know what you're referencing. You know what you're referencing when we throw around these very arbitrary bra sizes.
Yeah, because, bra sizes are definitely not necessarily breast sizes, because the bras fit a certain way, and that is affected by your back and the shape of your chest wall and the way that the material sits on your, like, there's so many things that have nothing to do with like the way that your breasts are going to look.
Right. And the company, Victoria's Secret notoriously upsizes. So everything, it's just, that's why pictures are super helpful to give us an idea of what it is that you are looking to achieve.
Right. And then we're going to talk to you about what's possible with your operation. And so having those photos, we can say, yes, that's happening, or no way, that's not happening, or you have a tuberous breast deformity that you didn't even know that you had. That's, why you're here. And we have to talk about how we're going to fix that. So there is a lot that goes into the consultation, where we're going to spend time examining you, talking to you, looking at all the possibilities, taking measurements. We're going to measure the base width of the breast. We're going to measure the distance from the nipple to the inframammary fold, which we just did the podcast, the IMF. And the inframammary fold is very important, and how we're going to manage that aesthetic unit, that space where the breast meets the chest wall. Those are things that we're going to talk about with you a lot, so that we can show you what kind of result we think we can get for you, basically through description and referencing your photos, because I don't think computer imaging for the breast is reality.
It's not as helpful, because that exam that you just went through is so critical. Having the surgeon able to feel the tissues, see how loose or how tight they are, do those measurements, which are so important, because that's when we can really tell you, yes, this is not a chip shot, but yes, we can achieve this with a primary breast augmentation, or no, maybe you need a lift with it, or you have that tuberous breast, we're going to have to do a little more work. So looking at what you want to achieve with the photographs and then doing the physical exam, we will be able to put together a plan for you to achieve what it is you're looking to do. And then that's usually when the topic or the discussion comes up of where we're putting the implants, what kind of implants we're going to use. And the basics of that are they subpectoral, which means under the pectoralis muscle, or over the muscle, which is considered subglandular. And in very rare cases will I do a subglandular breast augmentation. The rare exception for me in my practice is a tubular breast, which may be, not tubular, tuberous breast, which may benefit from a subglandular position. But even then, I try to not, if I can help it, just because that placement has a little bit higher risk of visibility, of rippling, and of capsular contracture. So if I can get the implant under the pectoralis, that's just a safer place for it to be.
How do you feel about subfascial placement?
Is
that a thing, or is that just I'm
ambivalent about the subfascial. Subfascial means that it's a different place. So it's over the muscle, but it's lifting up the fascia, or the connective tissue covering of the muscle, which in the most developed of bodybuilders is maybe a couple millimeters. In the average person, it's like a millimeter. And the idea is that you are walling off the implant from the subglandular space, so it's not touching breast tissue directly, and theoretically decreasing the risk of everything we talked about, the rippling and the capsular contracture rates, but you're not going under the muscle. The thing is, I feel like it's very polarizing. People that do subfascial do it a lot, and they swear by it. The rest of us just don't do it. So I don't do it. I can't really speak to it. The people I know that do it seem to think it's great, but I don't know a lot of people that do it.
I do it in bodybuilders, and I do it. I like it. I think it is different than subglandular, and I've kind of had really good experiences with that approach. So I can't, I like to bash techniques that I think suck. So I'm definitely the guy that's like, that doesn't work.
That sucks.
Stop. But at the same time, like, I can't bash it. I have a lot of bodybuilders that this is like a section of my practice is, these women who really, they pump some iron, man. They are not messing around. And that they don't want the motion.
That's the one population that I think would benefit from subfascial. Unfortunately, they usually have very little breast tissue, so they don't have a lot of breast tissue to cover an implant if it sits over the muscle. But because they do so much work with their pectoralis, they also can't have that implant moving around under the muscle.
Right.
And that's what's called animation deformity. In the average person, the average cosmetic patient, the animation deformity is not a big deal. Like, it moves a little bit when you do your chest presses or if you do a push-up or something like that, but it's not distracting, it's not noticeable, and it's not a big deal. In people who have had breast reconstruction, meaning they have no breast tissue, or bodybuilders who are kind of a different population as well, that animation deformity can be very obvious and very disturbing. So for that reason, yes, you can talk about subfascial. But otherwise, for the average person, at least in my practice, they're getting subpectoral under the muscle implants. My go-to is silicone. You have the option of silicone or saline. And I have some patients that come in and say, I don't want to have to worry about a silicone rupture. I know it's, not that big a deal, but I just don't want to have to ever worry about it. I would feel more comfortable with saline. Great, fine. But unless it's a patient that really is advocating for it, I just generally do silicone.
Silicone's the way to go. And there are all different shapes and sizes of silicone. I don't use anatomics. I
do not use
I think I did 3 anatomic breast augmentations when I was a resident back in Pittsburgh, and I uniformly disliked all of them.
Right. The anatomics are the teardrop shaped implants.
Do you know why they're shaped like tears? Because they make you cry. That's why. I know that's why they shaped them like that, because you're going to cry about your results. They're not good.
Yeah, they're not cute. I mean, the idea was well-intentioned, that you can make these implants that sort of mimic a natural breast, which has more volume at the bottom, less at the top, kind of give you that scooped out natural breast shape. But in reality, that's just not how they actually look. And the way they actually look is a little weird. They're kind of tall. They have kind of a funny shape to them.
Ridiculous.
And they're textured, which is not that's a whole nother podcast, textured versus smooth implants. But
we have done that podcast, by the way. I think that came up.
Yeah, the type of implant choice that you were going to choose, I would definitely look up our implant podcast, because it is a whole podcast going through implant choices and what the options are. Again, in my practice, average patient gets a smooth, round silicone implant of a medium cohesivity, which means that it has a little bit of firmness to it, but not the most firm, cohesive gummy bear implant that's out there, because those generally are reserved for reconstruction and are really heavy. So I kind of like the mid-range cohesivity, smooth, round silicone implant.
I agree 100% on that. I do not like the overly cross-linked silicone gel. That's really not even a gel. It's kind of like it's like rubber.
It's like a silicone like ball. I mean,
yeah,
it's
it is. It's like the cheek implants or something. They're really rubbery. They remind me, like when I was growing up, we had this doll called Stretch Armstrong, and you could take one arm, like my brother and I would try to like rip this thing apart, and you couldn't do it. So you just take one takes one arm, the other guy takes the other arm, you try and pull apart. These implants feel like Stretch Armstrong.
They do, and they are very firm and they are very hard. I used one just the other day for a breast reconstruction patient because she was super, super thin, and I knew that whatever I put in her, she was going to show rippling of the implant. So I chose the most cohesive implant I could to hopefully prevent that. But outside of that population, I don't use it in my cosmetic patients really much at all. So those are the implants, and we will go through that whole talk when you come in for your implant, breast augmentation. But once you sort of, determined exactly what kind of implant you want or you're going to have, and we've sort of honed in on the size. Let's go back to the size again real quick, because I do have patients that come in and they will say, I want a 400cc implant. My friend had a 400cc implant, and I want my breast to look like hers. It really doesn't work that way, because a 400cc implant on a 5'2", 100-pound girl may give her H-size breast, where a 400cc implant on a 5'7", 130-pound female may give her like a C cup.
Yeah.
So it really is based on your height, your weight, your base width, how much breast tissue you have naturally. If you have a decent amount of breast tissue already, You don't need a really big implant to get you really large. In fact, sometimes that's actually a problem. It's like, gosh, if I just do a lift and put a tiny implant in you, you're going to be huge. So how much breast tissue you come with, all of that factors in and determines what your final size is going to be. So don't get hung up on the CCs. Don't go down a rabbit hole of like CCs and this is what I need to get the look I want, because you may be right. You may get on the right track with that, but showing the photos to your plastic surgeon who does this all day, every day, I guarantee you they know what size implant you need. And if you just tell them and show them the look you want, they will be able to guide you with what's going to work for your body.
Yeah, and it's about the look too.
Yeah.
It's the what kind of look do you want? Like I sometimes will say, do you want this to be, something subtle and demure? Do you want it to be something that's like, wow, that really looks fantastic? Or do you want, people to crane necks to get a look? I mean, there's a spectrum.
A range, and all of them are fine, and all of them are great. But you just have to communicate what the look is. Again, going back to why you bring in photos, because it's like, oh, that's the look we're going for. Got it. But you do have to communicate what that is, because that is where we go back to our implants, because we didn't even talk about the profiles of implants. You can have low,
high profile,
moderate, high, extra high, and all of that's going to determine the final look of the breast. And that's going to be a discussion that you have with your surgeon based on the ultimate look you want. And that's why, again, that was a whole podcast, implant choices, because it is. But that being said, just show the photos to your plastic surgeon of what you want, and then sort of trust that they know what implant is going to work for you.
So I remember the first time I asked a patient to show me photos was I was a resident in Pittsburgh, and this patient was like, oh yeah, no problem. I'll bring in the pictures that my husband and I really like. Mm-hmm. And this gal brought in the hardest core porn I think I've ever seen in my life of some of these actors that she really liked. And I was like, I just like went red. And she was like, oh, I really like these. And she was like demoing them. I was like, okay, wasn't ready for that. But
that's helpful. Thank you.
What is that device, by the way? I need to, I have to wrap my head around. Okay, got it. No problem. I can't unsee any of this, and I will make you some very large breasts. Got the message. Done.
Right. Message received.
It was like crazy. I mean, I'm not a bashful guy, but I was like, okay, whatever. And then the other story that this one other patient said to me, whatever you do, I don't want to look like a porn star. And I was like, okay. So I made her these beautiful breasts, 400 cc's, whatever, 5'5" gal. And like 6 months after, she was like, remember when I said I didn't want to look like a porn star? I was like, yeah. She's like, I kind of want to look like a porn star. So can we upgrade these? So we had to go bigger. But, it's like everybody's got a different idea. I mean, some people just want to fill out their breast tissue to the way they were before they had babies. Some people want to, have just a little bit more to kind of make their hips and their chest match because they feel they're a little wider down here, and they want something up here to make the clothes and the proportion. So whatever it is, go for it. Just explain it, talk it out, show the photos of what you're thinking about, and then we can at least dial we can titrate the size of those implants and the placement and how they're going to look. I want more cleavage. I want this one. Those are all great discussion points for your consultation. And then obviously when you go to surgery, we want to like knock it out of the park for you.
Right. And the way I do it is I order a range of implants. We have a consignment here, so we actually have the whole range of implants. But I usually go in with an idea of like 3 or 4 sizes that I think are possible. Usually the one that I'm thinking in my head is the one I end up using. But I like options, so I order a bunch, and then we literally try them on. So implants come with what's called sizers. Sizers are exactly what an implant is, but they're not designed to be as durable or robust or whatever. I don't know how the company makes them.
They're actually just implants they're normal implants. They just don't basically put them through the process of making them ready for implantation.
For
but it's the same exact thing.
implantation. They're not designed to stay in permanently, but they are the exact same implant that you would otherwise get. And so we, make our dissection, we do our surgery, we open up the space, and then we put these sizers in and sit the patient up, take a look, and kind of look at the photos and be like, oh, I think that's too big, that's too small. We try on some other ones, and we can actually get a real-time idea of what the implants are going to look like. And then once we get the one that closest approximates what the patient wants, then those are the implants we choose, take the sizers out, put the permanent implants in. And for the breast augmentation patients, from a recovery standpoint, it's not bad. I would say 2-3 days of just chest pressure, if this is a primary augmentation, the first time you've had implants placed. That's because if we're lifting up that muscle and going under the pectoralis, it's sore, it hurts, it stretches, it's uncomfortable, but it's not awful. It's not the worst thing in the world. Most patients do fine. And after 2-3 days, pain subsiding, they're coming off the pain medicine. And for patients that have desk jobs, light duty, virtual type jobs, they can be back to work as soon as 3 days. 3 days to a week, I think, is very reasonable. No heavy lifting, no strenuous exercise for 6 weeks.
Yeah, I mean, that's the key. I mean, you want to kind of plan out to have this done. You want to have a good communication with your surgeon about what it is that you want. And then I want to add one point about breast asymmetry, because this is so all breasts are different. There are no two breasts that are the same. Even the two that come on our patients together are different. The right one's different than the left.
Always different.
Always different. They're different in volume. They're different in shape.
The nipple might be pointing this way on one side, this way on another one. Yeah.
So
and the thing is, you don't always notice that before surgery.
But you're definitely going to notice after.
Notice it after. For 2 reasons. Number one, breast augmentation, breast implants will enhance whatever symmetry is already there. That is true. Number one. Number two, you're not going to be staring at your breasts all the time in the mirror. I just had the cutest patient. I did her breast like 6 weeks ago, and she came in today and she's like, after I come home from work every day, I take off my bra and I just look at my breasts every day. Just want to make sure nothing's going wrong.
Well, she's into it. That's good.
So you become very obsessed with your breasts in the beginning, and you'll be looking at them a lot. And so you will now notice any asymmetries between the two. And they were there before, but you just weren't looking at your breasts every day to that degree of scrutiny.
Yeah. And so how you deal with it, obviously if it's a large discrepancy, we're going to have to use 2 different size implants.
Yeah.
But if it's a mild discrepancy in size and shape, I just tell patients I'm going to use the same size breast implants, and the asymmetry that you have will be your asymmetry.
Right.
And I try not, if it's 25 cc differences and 50 cc differences really turn out to then look like 2 different breast implants.
Right. I agree.
I don't love that.
I know. Unless you come in with a breast that's like a full half to a cup size different than the other,
then you have to.
I'm really not going to be doing different size implants. I think the last patient I had different size implants were significantly different. Like I think I did a 500 on one side and like a 700 on the other, and they look the same. Like that's how different she was. But doing like a 350 and a 385, it's not worth it.
No, and you will see that the breast implants are different. I swear to God.
They are, because they are wider, they are taller when they are different sizes, and so it's going to change the shape of the breast to a more unnatural degree than the natural asymmetry you already have.
Yeah, and I typically will explain that to patients just because they need to hear it. And the human body is just not symmetric. I reference the nostril asymmetry podcast. Right. I mean, we talk about facial asymmetry on multiple podcasts about facelifts. These are things that we deal with. And in fact, at our journal club last night, we were saying, all right, everybody, which side of the face is usually smaller? Left. Those things we know.
That's why I sit on this side of the couch. You can see my right side.
There's no good side for my face. It makes absolutely no difference. So I just sit right here. But that's the thing with breast augmentation. You want to have a clear path to a really good result. Knowing that there can be issues, any operation has complications that you have to deal with, and that's why you pick a great surgeon, because you find out how good your surgeon is when there are problems. When everything goes right, it's easy to say, oh, my surgeon's the best. But when there are problems, that's when you really learn who your surgeon is and how good they are for you.
Right. And there are always problems. The complications that you can have after a breast augmentation usually are pretty rare and not that common. Right away after surgery, there's always a chance of bleeding. If you have enough bleeding and blood collects around the implant, that's an immediate return to the OR.
Yes.
Find what's bleeding. Usually you can't find what's bleeding, but you wash out whatever blood is there and then put a nice clean implant back in. Because if you don't and you leave that blood to collect around the implant, you will have constant problems with that breast from a healing standpoint. It will always look different. The skin will be more stretched out. You may get an infection because the blood harbors bacteria. And then worst case scenario, you may have capsular contracture on that side. So from the beginning, bleeding is always a concern. Please don't do any kind of heavy jumping activity. Don't vacuum. Don't have sex. Don't pick up the kids from daycare. Don't put your kid in the crib. Like, just don't do a lot of heavy physical activity for the first few weeks because you can get bleeding anywhere out to 3 weeks from surgery. So there's bleeding. Infections, always possible. These are foreign bodies. In a cosmetic patient, I can't remember the last time I had a breast infection. It's just very, very rare for these things to become infected, but it's always possible. And then long-term risk of implants, that's where things get really tricky and complicated. And that's where a lot of the new consents and discussions that we're having come into play. Always the risk of capsular contracture. That's when the capsule that the body forms around the implant becomes hard and disfigures the breast. That's a whole podcast and discussion on its own.
We've done several on that, so just scroll back a little ways.
Go back and look through that. And that can come anywhere from 3 months to 30 years after placement.
For sure.
Capsular contracture. And then the ALCL, which is a very, very, very rare form of cancer, only seen in textured implants, which is why we don't use textured implants, but it does exist. That's part of the consent process. Yep. And then the new thing right now is BII, breast implant illness, which is a spectrum of diseases and symptoms which have anecdotally been associated with breast implants. So these are all things that we will discuss during your consultation and go through them with you and make sure that you're adequately informed and educated, because you now have to sign a special consent for all of these.
That's right.
The FDA has made it very clear
Absolutely.
that you have to have a very informed consent process about all of these potential risks.
Yeah. But the main thing is you're going to get some breast implants and be totally pumped.
The main thing is you're going to love your breasts afterwards. You know, they don't put that on the consent.
No. By the way, not responsible for your new ability to party in Vegas and to go to the beach and to wear amazing outfits and all the things that just kind of come up for people, which, you know, we hear about, you know, the renewed sense of confidence and how they love their look. It's, you know, it's great. It's not... you know, it is really for you. You do these operations, like we can say like, oh, you know, your photos and whatever, who cares about anybody else? It's for you. People do this so they feel good about themselves. Yep. And that's really what happens. I mean, we hear it over and over again, the how they feel like, oh, I just feel so much better. My clothes fit better. I love the way that I look. And you don't have to get big, giant implants to do this. You can get, you know, just a cup size bigger, just to fill out the
bra,
the bra a bit more, just to balance. I mean, I used to do a lot of really larger sized breast augmentations because that's what was in. Mm-hmm. The styles change. It is not that way today.
I would argue there's still a decent amount of people that want really large implants.
I have put in 800s twice in the last year. Okay,
yeah.
Fine.
So regional differences. There's just, I mean, that's the thing. Choose your flavor. Choose your style. I mean,
that's right.
And you can get whatever you want. You want a big, you want a small. Like, we got you. Like, just tell us what you want, and we can make it happen. The one last caveat I will say I think is very, very important for primary breast augmentation patients to know coming in. Yes, you're probably going to love these breasts, and yes, you're going to be super happy you did it. That being said, these devices are not designed to be permanent, lifelong devices. Right. Current implants have 20-year warranties against rupture. That's how long the companies believe they should last for. These are silicone implants before they rupture. You will probably need these implants exchanged before 20 years for cosmetic reasons. Changes in weight, pregnancy, childbirth, hormones. You want to be bigger, you want to be smaller. So usually for some cosmetic aesthetic reason, these implants will be swapped out before 20 years. you can always take your implants out at any time. Your breasts will not look as good, and they may not even look good, especially if you have very little breast tissue to start out with. So just know that if you're putting in implants for the first time, it's kind of a lifelong commitment to maintaining the implants or maintaining the appearance of the breasts, because this is, it's a not life-changing, can be life-changing, but it is a kind of a permanent change to your body.
Yeah, I mean, that's the truth. You're going to probably need another operation at some point.
At some point for these implants, and you have to know that.
Yeah, it's maintenance of the medical device. The operations aren't huge, but they take time and they have expense. They have risks associated with them. All that stuff is very real. We are the last people to sit there and look at any operation as being trivial. There is no trivial operation.
No. There's no, at no point do I ever walk into an operation and be like, oh, it's just a breast aug. I know people that do, and that is very distributing to me, because
it is disturbing. These are real operations.
Real
and I don't
operations.
think a breast augmentation is easy, by the way.
No. Every once in a while, you'll get that perfect patient with the perfect nipples and the perfect skin quality where it's straightforward.
But not easy.
But not easy to get like the result maybe that you and she have agreed on.
Yeah, I mean, I think there's so much artistry that goes into making beautiful breasts. I mean, that's why, you look on my website, there's cleavage galore, because I am all about that. I have friends who do way more breast augmentation than I do, and every one of their before and after photos, there's a fist-sized gap between the implants. If I did that over and over again, I would be very disappointed with myself. That's all. It's just not the look that I'm going for. I don't like armpit breasts. I don't like them wide on the... I am all about the cleavage. So there's, it's just, you got to look at those galleries. Once again, how are you going to pick your plastic surgeon? Get somebody that's recommended, somebody who's board certified in plastic surgery, and look at the before and afters. If you like the office, you like the surgeon, you're probably in the right place.
Can I just say one note about that cleavage thing? Because that's something that comes up a lot. People are very concerned about having the gap between the implants.
They should be.
You can't get cleavage without large breasts.
There you
That's
go.
the problem. You can't come in and say, I want to have cleavage, but I want to have a natural B-cut breast.
Right, so give me 200 cc implants on my 5'7" frame. Not happening.
If you want to have the implants come close together in the center, you're going to have a larger implant. That's just part of the deal.
Yes, you can't. There's no cleavage with no volume. That doesn't work. The cleavage comes from
you gotta kind of
the appropriate volume in the right place, with the right release of the muscle, with the right placement of the implant, with the right amount of lateral, displacement. You can't just. It doesn't happen by magic. There's a real, a high level attention to detail, artistry. The proper measurements, the level of experience. It's all the things that we talk about all the time. In order to really get great results, you got to be on that, like white on rice, when it comes to getting the right answer for your patient.
Look at the galleries.
Look at the galleries.
Look at the befores and afters.
That's right. You can go from there, because what you see on those galleries is what you are going to get.
Yep. So find the look you like. Find the surgeon that you really get along with, that you feel comfortable with, and then trust that they will give you what you're looking for. I mean, if you like their work and you show them what you want, then you have to kind of let go and say, I trust that I'm going to get the same results that they've given their other patients, that they understand what I want. And at this point, there's nothing more that I as a patient can do to guarantee a result. I just have to trust that they are going to provide for me what I'm looking for.
That sounds about right, Dr. Ravello. I'm really happy that we're getting back to basics on the Plastic Surgery 101 train. This is really good.
Yep, teeing it off today with the breast augmentation, and we will for sure have more topics to come.
In that case, this is the Plastic Surgery... sorry, it's not that. Actually, this isn't that. This is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.